First of all, I would like to thank the organizing committee of this international meeting for inviting me to participate and share with you some aspects related to obstetric antiphospholipid syndrome. In this lecture, I am going to discuss how new pathogenetic molecule cells may serve us to use new targeted therapy. As you already know, the gold standard, or the standard of care of the obstetric antiphospholipid syndrome is the combination of low molecular weight heparin in prophylactic dose with low-dose aspirin. However, according to some studies, 20 to 30% of treated cases did not achieve live births. So in these situations, we have to think in another therapeutic schedules. In this slide, you can see different cells, molecules, and receptors involved in the normal implantation and pregnancy. Some of them appear to play a role in the pathogenesis of obstetric antiphospholipid syndrome. Thus, any dysfunction in some of them would hamper the maternal fetal outcomes. Although classically defined as a primary thrombotic disorder, obstetric antiphospholipid syndrome have a dual pathophysiology, being primarily an inflammatory disorder, complicated later with clot pathway activation. Thus, only 50% of placentas show clearly an isolated thrombosis. In the remaining cases, inflammatory signs in absence of infection and complement protein deposits can be seen. Overall, these slides show diverse cells, receptors, and mediators involved in obstetric antiphospholipid syndrome. I would like to stress that myeloid cells, complement system, Th1 cytokines, mainly TNF-alpha, and the angiogenic cytokines, adhesion molecules, and reactive gene species are involved in this pathological and complex process. In more detail, we can see in this slide thrombotic and non-thrombotic lesional mechanisms involved in the pathophysiology of obstetric antiphospholipid syndrome. They include a possible effect of APL on trophoblasts. Although not included in the CINI criteria, a lot of papers appear to associate APL with recurrent implantation failure. Recent meta-analysis by our group shows a clear relationship between some APL, mainly anticardiolipin IgG and anti-beta 2 GP1 IgA, as a possible negative effectors on the placenta formation. So we have to consider the possible role played by APL in all this APL-related morbidity. This slide shows that APL may interact with myeloid cells that activate the complement system. In addition, the fraction C5a may in turn bind to monocytes and neutrophils and activate them, thereby secreting net pro-inflammatory cytokines, mainly TNF-alpha, and angiogenic cytokines, and subsequently tissue factor delivery and increasing the ROS reactive gene species burden, provoking eventually the trophoblast injury. Thus, you have molecules to be used as a therapeutic target, for instance, TNF, complement proteins, receptors for these complement proteins, membrane attack complex, tissue factor, nitric oxide, and its receptor, etc. In addition, the production of APL and antigen antibody complexes requires the previous work of T and B cells. I mean, the participation of innate and adaptive immune pathways. Accordingly, different intracellular signaling pathways are involved, mainly nuclear factor kappa beta, MYT88, and mTOR, the mammalian target of rapamycin complex. Altogether, they offer us, again, new possible targets that may suppose new therapeutic opportunities. For instance, corticosteroids for blocking nuclear kappa beta, rapamycin sirolimus for mammalian target of ravaging complex block, and small molecules that are currently in study for MYD88 signaling pathway blocks. In the right side of this slide, you can see drugs that have been used in APS, and in red, those that have use in obstetric antiphospholipid syndrome women. In this figure, focus in lymphatic nodes in blue arrow, vascular wall, red arrow, and placental tissue, green arrow. You can see in more detail the possible molecules and receptors involved in the pathogenesis of APS, and they can be used again as a therapeutic target. In the lymph node figure, I underlined the main actors involved in the starting classical antigen-specific TB immune responses: antigen-presenting cells, T and B lymphocytes, and co-stimulated molecules, for instance, CD40, CD28, CD80, and CTLA4. In the vascular endothelial cells, in red, where stand out platelets, monocytes, and granulocytes, and endothelial cells as the main involved cells. In addition, prominent molecules and receptors has also been stressed. For instance, ApoER2, membrane phospholipids, glycoprotein 2B3A, and thromboxane B2 in platelets, and also TLR4, C3 activate protein complement, cissin receptor, vascular endothelial growth factor, anti-angiogenic cytokine ISLT1, and tissue factor. In trophoblast, green arrow, we underline also receptors as ApoER2, TLR, C5a receptors that, once activated, may mount a pathological immune reaction with the subsequent activation of membrane attack complex and delivery of anti-angiogenic cytokines, Th1 cytokine, and high amounts of reactive ogens species, eventually producing a marked tissue injury. In this slide, you can see different therapeutic approaches focused in targets related to B and T cells. Rituximab, for instance, is able to bind to CD20, thereby inducing the cell death via antibody-dependent cellular cytotoxicity. Belimumab is able to bind the BLyS and BAFF, eventually blocking the B-cell activation. But really, belimumab have shown to have a poor capacity to decrease the APL formation or synthesis. Abatacept has not been used in OPS patients. Interestingly, low molecular weight heparin and fondaparinute are able to bind negatively target phospholipid or phospholipid antiphospholipid complexes. Furthermore, corticosteroids are able to interfere with the union between the HLA class II and TCR, impeding a correct specific TB signaling and also promoting T-cell apoptosis. From the vascular point of view, different cells and molecules can be used as a targeted treatment. Thus, drugs such as adalimumab, prednisone, hydroxychloroquine, ELDA, low-dose aspirin, complement inhibitors, eculizumab, olindalizumab, pentoxifilin, statins, low molecular weight heparin, high-dose vitamin D could be used according to their pleiotropic mechanism of action. They can be used in combination to obtain better effectiveness. Similar slide showing in more detail the exact point of action of these drugs. as you can see, some drugs exert pleiotropical beneficial action in this pathology. This slide, you can observe some specific targets on trophoblast cells. Hydroxychloroquine, for instance, acting on TLR, statins improving the angiogenic and anti-angiogenic ratio, along with its capability to reduce Th1 cytokine delivery and reducing the HLA-DR expression in T and B cells, may act as an interesting, a promising drug. Low molecular weight heparin and fondaparinux, also with pleiotropic actions, partially blocks the complement activation, binding to TNF, reducing the trophoblast cell apoptosis, and may bind also to negative charged phospholipids, so being, as you can see, really interesting pleiotropic functions. Prednisone, for instance, acting of nuclear factor kappa beta, reducing the secretion of Th1 cytokines or diminishing the burden of NK cells, right, may also act as an interesting drug in decomplexes or refractory cases. In summary, it supposes a reduced inflammatory pathway, less oxidative stress burden, a better trophoblast placental cell survival, and eventually avoiding fetal and maternal APL-related complications. And with this power slide, you can see the pleiotropic actions of some drugs according to the specific targets. Really, old and new drugs, due to their pleiotropic effects, may help us to better treat these patients. In this slide, you can see different clinical studies done on specific drugs in the field of obstetric APS. You can see the good results of hydroxychloroquine, the TNF blockers, and the eculizumab when have been used. In the next slides, we can see diverse details related to the most used and also some futurable drugs on APS refractory cases. So, on corticosteroids, as you previously commented, exert different pleiotropic effects. The antibody synthesis diminution or interfere with the ATP-antitrypsin network, lower complement activation, increase the T-cell apoptosis, etc. No placenta fetal adverse effects with reduced doses, when reduced doses are used, have detected. Some studies published would result when associated LDA with LDA and or heparin. So, in a clinical, from the clinical point of view, the corticosteroid use a low dose, 10-15 milligrams per day, in the first weeks of pregnancy could be a useful drug for these refractory cases. As I previously mentioned, TNF-alpha is a major pro-inflammatory cytokine in the uteroplacental milieu. Its inhibition could help women with OAPs. There have been few papers published with preliminary good and hopeful results. We have some experience in using the TNF-alpha blockers in these cases, and you can see in this slide, it's a personal series of women that failed with the standard of care recurrently, even when hydroxychloroquine was added to the standard of care. Once TNF-alpha inhibitor was added, adalimumab, in some cases certolizumab, 70% of women have a live birth. Currently, with the more women included, we have achieved almost a 75% of success with no adverse effects. 2 words on intravenous immunoglobulins. There is no agreement on its effectiveness when treating idiopathic recurrent miscarriage. On the contrary, papers, including some of us in collaboration with Dr. Rufati and Dr. Tincani, showed promising results when high-risk patients, those that experience thrombosis or those who have obstetric morbidity, along with triple APS positivity, cases have a good results. Statins deserve special comment. Although formally not recommended by the national regulatory health agencies, there is no rationale for doing it. Statins have absolutely safe during pregnancy. Statins are the capability to regulate negatively the immune response, and particularly the capability to induce down-regulate anti-angiogenic vascular cytokines, make hydrophilic statins very interesting for treating pregnancy-related APL. In addition, they have been taken by oral route, they are cheap, so currently there are 2 randomized clinical trials to analyze its effectiveness and risk in this case of patients, including preeclampsia patients. So different papers have been published in the last years, but the group of Professor Lepku and Professor Girardi, with a very, very good results in APS related to obstetric morbidity. As you can see in this slide, the main uterine artery pulsatility on velocimetry really falls dramatically when statins are used. We have also some experience using pravastatin in this kind of patients, and as you can see in this slide, once the statins, in this case pravastatin, at 40 milligrams per day have been introduced, have induced a marked decrease of uterine artery pulsatility, a decrease of SLT1 antiangiogenic cytokine, and a very, very interesting and marked decrease in the ratio between antiangiogenic and angiogenic cytokines. So, taking this data all together, we think that the statins is really a promising drug to be used in no complicated cases of obstetric antiphospholipid syndrome. In this slide, we can see to date, and according all stated previously, the guidelines we follow to treat high risk or refractory cases is as follows. Step 2 is the combination of the standard of care plus hydroxychloroquine accordingly to body weight. Step 3, the same as plus low dose prednisone or using increasing low molecular weight heparin dose. The next step is the same plus adding intravenous immunoglobulins. Step 5 is the same with or without immunoglobulins, but adding anti-TNF-alpha. We use adalimumab or certolizumab. And finally, in certain cases, statins could be used. Obviously, eculizumab in cases of very, very complicated cases that evolve to a complex thrombotic storm. This slide, you can see in more detail the schedule we used in these cases. At low corticosteroid, TNF blockers, pentoxifylline, intravenous immunoglobulins, eculizumab, and in some cases, statins. The future lines and expectancies. In brief, more targeted driven therapies are coming. Treatments directed to domain 1 and domain 5 of beta-2-GP1 are ongoing. The immune regulation related to microbiota should be considered as an adjuvant measure in the future. Omics may help us to get the therapeutic excellence and personalized schedule. It will continue of being difficult to perform well-designed studies because the pregnancy is a limiting factor. So, and meanwhile, approaches related to evidence-based clinical practice, clinical expertise, and common sense, along with the patient-centered medicine approaches, should guide our management of this syndrome. And finally, in my opinion, the more proactive therapeutic measures used, the best maternal fetal outcomes obtained. Thank you very much for your time or for your kind attention.